So what does it mean to us? Um, I think there's a few implications. One is that pain from the gluteal region have a multiple contributor. There's a different muscles. We can have a piriformis syndrome. We can have the obstinate internus syndrome. We can have a ischio-femoral impingement syndrome in which the quadratus femoris is involved, and we can have a hamstring, possible hamstring syndrome when the ischiotibulosity attachment from the hamstring, origin from the hamstring is involved. And you can have a multiple neuropathology, so it's not just that a simple picture with a sixth variation of sciatic nerve. It can have a nerve muscle interaction, just like I'll show you that the S3 can be entrapped inside the piriformis muscle. You can have a fibrous band or fibrovascular band involvement, like what I show you in the endoscopy. And we can dynamic compression and traction, which I show you in dynamic ultrasound. And we can have a different nerve involvement because the deep gluteal space, the sciatic nerve is not the only residence. They are superior and inferior gluteal nerve, posterior cutaneous nerve, and then the inferior cranial nerve and pudendal nerve. And finally, the role of surgical management. So in the past, there's not a lot of surgical management options we have. We can talk about injections, we can talk about excision of the piriformis muscle, but now we talk about the fibrous band release, we talk about decalcification, we talk about laparoscopic approach for the detriment of the S3. So there's a much more options, especially surgical options. So approach a patient with the pain in the gluteal region, I think is very similar to a real estate agent. Locations. When someone presents with the pain in the buttock region, there are a few areas that you want to highlight, and like in the piriformis area or in the possible hamstring is a bit lower, and ischio-femoral impingement is deeper. Now I don't put all the four different syndrome exactly over inside the GGS because there is a certain presentation of those four syndromes that present outside the gluteal space. So I think there's a lot of overlap, but this is good enough. And don't forget one other thing is that we call the refer pain from the lumbosacral junction that we can refer for the buttock, and typically S1 nerve root pain can refer to the buttock area, and they can have some tingling down in the lower limb as well. Okay, let's talk about piriformis syndrome. There's a clinical diagnosis mainly by excluding the spinal and the pelvic cause, and the prevalence is unknown, but around 0.3 to 6% of a patient with low back pain may have piriformis syndrome. Again, we talk about different tests. Primary piriformis syndrome is not as common as a secondary. Primary can come probably maybe 1/6 of the cause. Secondary, like repeated activity or overuse of the hip area, direct trauma, link discrepancy, or real pocket wallet. I mean, someone who have big wallet and just pressing on the area, or even tumor. The management, I think physical therapy, and this is one of the type of exercise you can do. And what the philosophy is to elongate the piriformis, because the philosophy of piriformis is because it have such an intense muscle activity, and is causing the pain in the gluteal region. Well, there is some medication people can use non-steroidal, and I find one of the article very interesting is RCT on using mannitol and vitamin, and don't ask me, but I have no idea why it work. And injections, many different ways have been described. Injection of a dry needle, acupuncture without touching the piriformis muscle, injecting local anesthetic, or local anesthetic with a steroid, or you inject Botox. And a different modality have been described. You can have a blind technique, you can have a EEG or EMG directed technique, you have a CAT scan, ultrasound, and fluoroscopy. So you have a whole array of this. Now, I'm going to summarize this by what is a known. Well, most of them, they are serious case cohort. And because of this, all work. Well, this is a very recent article published just last year about the treatment and summarize all the extensive literature on those injections intervention in piriformis. But just remember, what is the name of the game for the case series of the cohort? It means good news. They publish good news. So that's the reason why it seems it always works. Well, I'll give you a little bit more about the known. One is addition of the steroid to the local anesthetic have no added benefit. So people have looked at this in a randomized controlled trial. And they actually study all the way up to 3 months and see there's no improvement in both the pain and also activities. The second is, what about ultrasound versus X-ray? Interestingly, there is I know the group of authors. There's a randomized controlled trial, to compare the two techniques, and they find that the ultrasound have no difference compared with X-ray between the two techniques. Okay, so it's published in a good journal, and we wrote a letter to the editor and say this is ridiculous. Why? Well, when they say there's no difference in all this, okay, I get it. I respect science. But when they show you the picture, I don't know what you make up from this. This is the greater tuberosity and this ischiotuberosity. In between, they put a needle there. For those who understand the anatomy, know that between the ischiotuberosity and greater trochanter, this is a classical site, for chordatus femoris. Is no piriformis, my friend, here. They are injecting here and not here. And they show the sciatic nerve, gluteus maximus, and this is a classical site for gluteus maximus. And see what they label here? Piriformis. This is such a wrong article, and I don't know how they can get through the peer review. As a matter of fact, no doubt ultrasound is much better than the X-ray, and there is a study compared with this and find that the X-ray have been validated that only have a 30% success rate compared with ultrasound. So I think it is no doubt that in piriformis syndrome, the target is a muscle, is a soft tissue. X-ray is not a imaging modality to look at the soft tissue. Ultrasound is. So there's no doubt that ultrasound should be the one that prefer over the fluoroscopy. The other known. What about Botox? People have also looked at the role of the Botox. They find that actually compare with just a physical therapy and Botox, there's no doubt that in terms of pain score is much better with the Botox compared with no Botox. I think the Botox certainly have a certain role, especially it is long lasting, around 3 to 6 months. All right, I talk about injection. What about surgical management? This is a very good article again published 2 years ago about surgical management, and I think I'm not going to say yes or no because again it's also a case series. But I just want to let you know is there's a lot of surgical approach available now, and a lot of them are that make sense. So I just want in the past I'm very resistant to those surgical approach because they just removed the piriformis. But now we are talking about decompression. They can see the band. They can actually do different things that can help to alleviate the piriformis syndrome. So I just want you to keep an open eye, an open mind on those surgical techniques, especially when those are coming from the reputable center. Well, we are anesthesiologists, and when we do injections, I think one of the classical protocol we suggest is go from the iliac crest there first. From there, you can see three layers of muscle: gluteus maximus, medius, and minimus, and you can see the superior gluteal artery. And you slide down, and then you see a two-layer relationship: the gluteus maximus and piriformis muscle. And then opposite to the tip of the ischium, you can see a sciatic nerve there. And so you need to see the sciatic nerve, you see the gluteus maximus, because you need to define the deep and superficial border of the piriformis before you can inject or insert a needle into the piriformis muscle. And the other thing is about the insertion of the needle. And if you actually insert the needle just besides the ultrasound probe, you may not be able to see a needle because of the steep angle. What I suggest a lot of time, actually, you put the needle just a bit further away from the probe, like 2 centimeter, then you have a more favorable angle. The angle will be much more favorable so that you can see the needle with the ultrasound probe. It's just a scan to show you one way to augment the visualization of piriformis is by internal external rotation. And by internal external rotation, you can see there's some, let me just see, I can just go back here. By internal external rotation, you can see the piriformis gliding over there, over the sciatic nerve, and you see the inferior gluteal artery bouncing within that neurovascular bundle. And this is a picture, so you do in-plane from medial to lateral. Well, that's much about the injection technique. What about obturated internus syndrome? So we call obturated internus Gemini muscle. So not a lot of literature about this. What we know is, the known is the presentation overlap a lot with piriformis syndrome, but it may augment the symptoms of piriformis. So what does it mean is, if a patient you think it's piriformis symptoms, and you do Botox, have some partial relief, you may actually want to add the piriformis to the obturated internus muscle. Or can you inject? Well, just remind you that the obturated internus, if you use the ischium as a border, on the medial side is obturated internus, on the lateral side is more the smaller muscle, and maybe even the tendon. So much easier to actually inject into the muscular part. So I just want to show you that in terms of the how we augment the symptoms, is a slide that I showed you before, that the obturated internus and piriformis can have common insertion. So in that case, it can actually augment the grouping of the sciatic nerve, and the other possibility is the overactivity of the Gemini muscle. So when you do the internal rotation, if you have very strong muscle here, you can actually make it bulge out and causing more kinking and more issue with the smooth contour of the sciatic nerve. That's the contribution of the obturator and Gemini's muscle. How do you inject? As I say, is on the medial side or ischium. The protocol is very similar to injecting piriformis. You go from iliac crest first, and then go to the sacroiliac fossa so that you can see the piriformis, and then go to ischial spine when you see the ischium become long and straight, and you can see the pudendal artery. But then the next thing is to go to the lesser sciatic notch. That's how you see the obturated internus. So when you are in the lesser sciatic notch here, the ischium become from a long and straight become a very curved, like a red line here. And the obturated internus is on the medial side. And the upper part of this, you don't want to touch because it's an alcohol canal, there's a neurovascular bundle. In case you are interested, you can see the ischiotubulus ligament, and the coccygeal muscle, and levator ani muscle here. So this is a quick scan. This medial is lateral, is in ischial spine, so iliac crest, and then the piriformis, and then now in ischial spine. Long and straight is a medial, is a lateral. And then later on, when you scan further, the bone contour will suddenly become very curvy. And you can see here it's all black here. So this is the silhouette of the obturated internus muscle. And this is the area you don't want to inject because it's the entrance to the alcohol canal. You inject deep here. So when you put a needle, this actually inject into the alcohol canal. You want to direct the needle actually much closer to here. All right. And I think it's very long lecture. I will just cover the ischiofemoral impingement, and I will be done. So it's first described in 1977, following the total hip replacement. What it described is a narrowing of the space between the ischiotuberosity and the lesser trochanter. And what is at risk here is the muscle called the quadratus femoris. So when the two bony structures are close together, they entrap and impinge on that muscle and can be quite painful. And here is some extreme example. You have very prominent lesser trochanter that make it very closer to the ischiotuberosity, and then in between the quadratus femoris is not having a good time. So again, is a is ischiofemoral, the lesser trochanter here, and this is where the quadratus femoris go through. You can see the difference here is not just is more narrow, the muscle also appear white. Why is white in T2 means water. That means the muscle also have some edema there. So I think that when you diagnose the ischiofemoral impingement, you need to have three component there. One is radiologically, the patient have a decrease in distance in the ischiofemoral space between the lesser trochanter and the ischiofemoral. The second, you have to demonstrate that is functionally is really narrow in impinge on the quadratus femoris, and I would like to see whether there is some swelling there. And the third is a clinical, whether it is clinically important. So between the lesser trochanter and ischiofemoral, whether it's impinged, well, by some particular movement. And one of the movement I would love to use is called a Johnson's test. And when I basically have the leg extended, abducted, and external rotate. And you can do it when the patient is standing, or you can do it when the patient is lying down on the side. When the patient have a clinical provocation, when they have a pain on provocation, when the patient have a narrow distance between lesser trochanter and the ischiofemoral, when I see a swelling of the quadratus femoris, then I would say this is time to say it's true. What is the number to be right? And there is a meta-analysis, and I think I always say that the distance have to be less than 15 before I catch any attention. But when it's less than 10, I think the specificity is more likely to be the case then. Management, physical therapy, as well as a pharmacological. But a lot of time, I will just defunction. So is a swollen, is a muscle, I just defunction, make it smaller. So how can you make a muscle smaller? So that because the bony space is smaller, the muscle jam inside. But if you make the muscle smaller, then you don't have a problem. How can you make muscle smaller? One of the best tool is repeated, not just once, repeated injection of Botox. But you know that when you repeatedly inject Botox into a muscle, the muscle will substantially smaller with atrophic changes. So that's one of the treatment. So remember, when you do Botox, don't expect one injection is good enough. You need to have a repeated injection. Tell the patient you probably need to 2 or 3 injections to make the muscle very thin. There's some surgery, obviously, because you can treat a secondary cause and resect the lesser trochanter or treat the rotation of the lesser trochanter. I think we have covered quite a lot today, so I'm going to stop here, but I just wanted to give you a take-home message. I would like you to just now understand the concept of deep gluteal syndrome and how it arrives. It's basically a pain in the gluteal region with sciatic pain of extraspinal origin. It really encompasses a different structures, different nerve, different muscles, and different etiology. And the sciatic nerve can be affected by different mechanisms like muscle-nerve interaction, fiber span, etc. So we needed a dynamic ultrasound scan. We can even use MRN. And the measurement depends on the cause. And I think a multidisciplinary approach with physical therapy and the injection will be a reasonable approach, but in some special circumstances, we need a surgical colleague to be involved. With that, thank you very much.